Let's start with the basics. The pleural space is a potential space between the lung and the chest wall, normally containing a tiny amount of lubricating fluid. Empyema is when that space becomes infected and filled with pus. It's not just a simple pleural effusion, it's an infected one. The most common gateway, an underlying pneumonia, accounting for over half of all causes. Empyema doesn't happen overnight. It progresses through 3 pathophysiological stages, and your treatment decisions hinge on recognizing which stage the patient is in. Stage 1, exudative. Animation shows clear fluid accumulating. This is a simple, sterile inflammatory response. The fluid is free-flowing, has a normal pH and glucose. The lung can still re-expand. Treatment, often antibiotics alone. Stage 2, fibrinopurulent. Animation shows fluid turning yellow pus and strands of fibrin forming webs, creating loculations. This is the turning point. Bacteria invade. Fibrin deposits create loculations, walled-off pockets of pus that are hard to drain. The fluid becomes acidic. Glucose drops. Treatment, you need drainage, now a large bore chest tube, often with fibrinolytic agents to break up the loculations. Stage 3, organized. Animation shows a thick, white fibrous peel forming over the lung, trapping it in a collapsed state. This is the chronic phase. Fibroblasts create a thick, inelastic rind around the lung, preventing expansion. The chest wall may even contract. Treatment, at this point, you need a surgeon. This stage requires decortication, surgically peeling this rind off the lung. So what do you see at the bedside? Think of a sick pneumonia patient who plateaus or worsens. They have persistent fever, pleuritic chest pain, and shortness of breath. On exam, you'll find dullness to percussion and absent breath sounds over the affected area. Diagnosis starts with a high index of suspicion. A chest X-ray shows the effusion, but bedside ultrasound is your best friend. It can immediately identify complex, loculated fluid versus simple fluid. The definitive test, diagnostic thoracentesis. You send that pleural fluid for gram stain, culture, pH, glucose, and LDH. Remember stage 2. You're looking for that pH 7.2 and glucose 60 mg or DL. Management is a ladder, and you climb it based on the stage.